Moving on to the second topic, it is approach to fever in the ICU. The fever is always tricky, even when the patients are not in the ICU, and more so when the patients are in the ICU. When they are sick, we need to differentiate whether it is infectious cause or non-infectious cause of fever, and then if it is infectious, when to start antibiotic, when to de-escalate the antibiotic, and what is the syndrome. So to cover this very important topic, because the risk associated with the infections in the ICU is very high, we have Dr. Rahul Sampath, who is internal medicine program director and chief of staff of University of North Carolina Health, Blue Ridge, USA, and is also chief of infectious disease at University of North Carolina Health, Blue Ridge, USA. He had his initial training MBBS from Kasturba Medical College, Manipal, MD in internal medicine also in Manipal, and then he had Baylor College of Medicine, USA, fellowship in infectious disease from Mayo Clinic, Rochester, USA. His special interests are HIV, vaccine development, and infections related to surgery and transplantation. And he's been the recipient of Joseph E. Gerasi Award in Infectious Disease from Mayo Clinic. Over to you, Rahul, for the lecture on approach to fever in the ICU. When and
Thank
how
you,
to
Kavita.
start antibiotics.
Quick question, Kavita. I'm trying to share my slides, but it says somebody else is sharing. I've sent a request, but it says the
Yeah,
host isn't
Bala,
allowed.
you have to unshare, stop sharing.
Sir, it has been stopped. Can you share
It
now?
has been stopped, madam. Already stopped.
Yeah. Rahul, you can start once again. Try.
All right. Are you guys able to see my screen?
Yes.
Okay. All right. So thank you, Kavita, for inviting me and for that introduction. And thank you, Dr. Verma. I think you're on today. I don't know if you remember me as a fellow, but I can tell you one thing: all my batchmates love to rotate with you during their training. But I also wanted to thank two people, if I can have the opportunity, who shape the way I practice medicine right now. And that's Dr. Ram Bhatt, who gave me a very rigorous cognitive framework. I think about the 6 months I spent with Dr. Ram Bhatt, and I still get a little stressed out and my heart rate goes up. But there's no better mentor than Dr. Ram Bhatt, at least for me in my life. And also Dr. Hande, who gave me a rich emotive framework within which to care for patients. And he was the person who always I drew a lot of inspiration from him. So I owe these two giants in medicine a great deal, and I may never have a chance to pay them back in full, but I hope I can continue to pay their influence forward in some way or form. So it's like Kavita said, this is a very important talk. It's a very big talk. So I'll give you an overview, but I'll go into some of the evidence-based approaches to fever in the ICU, and I'll try to make it on time. And please feel free to let me know if you want me to rush along the slides. So our first slide, we'll just start with a basic understanding, some general points. So fever is very common in the ICU, but rates range from about 25% to 90%, depending on which fever definition you use and what's the case mix index. Are you working in a surgical ICU, a trauma ICU, a neuro ICU? So prevalence numbers are a guide, not an absolute truth. And physiologically, fever is basically a regulation upwards in your hypothalamic set point, and it's driven by cytokines and other mediators. So that's different from hypothermia, where temperature control is completely lost and the body can't effectively dissipate heat. Our normal core temperature generally fluctuates over the day with the behavior. People who tend to run a little low in the early morning and higher in the late afternoon, with the temperature rising when we eat, when we exercise, when we're sleep deprived, and for women in the luteal phase of their menstrual cycles. The point is that not every temperature bump is pathological. And when we evaluate fever in the ICU, we have to consider timing, baseline, and context before launching into a large infectious disease workup. So a little bit about the significance in the ICU, the SCCM and the IDSA, which are two large groups of researchers, define fever as a single temperature of 38.3 or higher, or 101 degrees Fahrenheit. That gives us a very practical threshold, mainly for studying and epidemiological purposes, but it's important to remember that fever itself is neither sensitive nor specific for infections. About one-third of all septic, actually one-third of all septic patients will present without fever, and about 10% will be hypothermic when they present. So if we rely on fever only as a screening test for infection, we'll miss a lot of sepsis. But at the same time, when fever does occur, it can be adaptive. Some degree of temperature elevation can improve your leukocyte function and pathogen killing. And the absence of fever in sepsis is actually a bad prognostic sign, where hypothermia and even normothermic septic patients tend to have a higher SOFA score and higher mortality than those who mount a febrile response. So basically, the ability to generate a fever often reflects some sort of a better physiological response. So this is the best epi data that we work on. So Lopland and colleagues retrospectively looked at about 24,000 ICU admissions to understand how common is fever and what it means clinically. So using that 38.3 as a degree centigrade as a cutoff, they found that about 44% of ICU patients developed fever at some point, and about 8% developed high-grade fevers above 39.5. A key finding was a very weak correlation with proven infection. Only about 17% of people who had fever and only 31% of high fever had a positive culture. In other words, most fever in the ICU may not be microbiologically documented infections, which is why fever alone should not trigger automatic antibiotics. They also found very high fever is a marker of severity. So temperatures above 39.5 were associated with increased mortality of about 20% versus about 12% in those without high fever. So fever is non-specific, but extreme fever does track with some mortality data and sicker patients. So I'll spend a little more time on this slide because as you approach fever, the first thing is for you to understand and rule out non-infectious causes of fever. About half of the febrile patients ultimately will have a non-infectious cause. Early on, we still have to think about infection, but keeping these alternative causes in mind help us avoid reflexively starting broad antibiotic therapy or calling every fever sepsis. So post-surgical fever is one of the important examples. About 30 to 50% of surgical patients will have a temperature rise in the first 48 to 72 hours after an operation. In stable patients who have had shorter or less extensive surgery, these fevers are usually quite benign and they're just inflammatory responses to tissue. Importantly, atelectasis does not appear to have any association with fever. If fever that starts or persists for 3 to 4 days after it starts, or starts after 3 days or 4 days, 96 hours is usually used in a lot of studies, especially after long complex bowel or cancer surgeries, that's more concerning for a true infection. Drug fever is another a major cause of fever. About 10% of hospitalized patients will have medication-induced fever at some point. In the ICU, common culprits will be anticonvulsants, antibiotics are a big cause, chemotherapy, sometimes diuretics, anything that started newly, antihypertensives, antiarrhythmics, heparin. Occasionally, case reports of fentanyl, propofol, and dex also causing fever, but it's quite rare. So transfusion-related fevers are also frequent. Febrile non-hemolytic transfusion reactions, which are defined as a temperature rise of about 1 degree centigrade during or soon after the transfusion, are also more common. And these are more common with red cells and platelets, and these are usually benign. And rarely you can see transfusion-related acute lung injury or acute hemolytic reactions or septic transfusions, but these are extremely rare but are important to consider when no other cause of fever can be identified. So non-infectious fever is particularly common in brain-injured patients. So people with brain injury, intracranial hemorrhages, or strokes, or spinal cord injury, usually happens in the first 48 to 72 hours after the neurological event. And during this 48 to 72 hours, infection is quite unlikely as the cause of the fever. And it usually reflects some central dysregulation. These fevers do correlate with the worst neurological outcome, which is why we usually treat the fevers aggressively. But our aim is usually normothermia. And there's a lot of data, especially in out-of-hospital cardiac arrest, that says that normothermia is probably a reasonable goal rather than hypothermia. So venous thromboembolisms is often blamed for fever a lot of time, but DVT alone rarely produces very high-grade temperatures. Fevers above 38.3 occur in fewer than 5% of confirmed cases. PE can cause associated fevers, and the higher the clot burden, the higher the fevers, but persistent high fevers should again prompt a search for some other source. Something that's usually missed is withdrawal states, particularly with alcohol and benzos, but sometimes with the medications that we give during the ICU stays. They can also contribute to low-grade or moderate fevers, and typically about 24 to 72-hour window is when you'd see the withdrawal signs. It's usually associated with some degree of autonomic instability too. And finally, we'll look at some true hypothermia syndromes and differentiate them from ordinary fevers. When temperature climb above around 41 degrees, infection is really less likely. We should think about, serotonin syndrome, neuroleptic malignant syndrome, or malignant hypothermia. And these are driven by excessive heat production or impaired thermoregulation, and rather than a reset set point. And they often have characteristic features of the drug exposure, either anesthetic agents, sucks, or the fluorinated anesthetics, or or severe rigidity and clonus on examination, or marked autonomic instability. And there's some subtle differentiating factors that can differentiate these. All right, so we'll go to our next slide, and this is basically a general approach to fevers in the ICU based on the 2023 IDSA CSM guidelines. Like I mentioned before, the temperature that they use is 38.3, and when you do hit that threshold, it shouldn't reflexively lead to a bunch of labs and scans, but it should trigger a focused bedside examination. History and examination can give you much more information than a lot of other things, and that's your foundation block. The first question is, does the patient have a clear non-infectious explanation, such as immediate post-op day one of a major surgery, or a classic transfusion reaction, or a clear drug or withdrawal fever? And the next question is, are they hemodynamically stable? So if yes, if they are hemodynamically stable, extensive testing, empirical antibiotic therapy may not be necessary. But if there's shock, new organ dysfunction, with no other clear explanation, that's when you have to escalate the diagnostic evaluation and consider empirical antibiotic therapy. For labs in microbiology, the guidelines are pushing us away from a shotgun culturing approach. When we send blood cultures, we should send at least a couple of sets. If you're suspecting endocarditis, like it was mentioned in the last presentation, 3 sets, roughly 60 ml of total blood from different sites at a minimum. So about 25 to 30 ml per draw. And if there's a central line, draw from both the line, all the lumens, and the peripheral site, and look at differential time to positivity. In practice, only about 5 to 13% of blood cultures are truly positive, and only 2 to 6% and 2 to 6% are contaminants. So let's say if you send 100 blood cultures and 13% are true positives, and you send 100 blood cultures and 6% are contaminants, out of all the positive blood cultures, the number of false positives is pretty high. It goes up to about 20%. So the key is use pretest probability before you order a blood culture. Urine culture should be sent when there's pyuria and a real suspicion for UTI. In catheterized patients, it's better to replace the Foley catheter and culture from the new catheter rather than from the old colonized catheter. Respiratory cultures are reserved for patients with a new respiratory symptoms or a new infiltrate, and not every febrile or ventilated patient. So on imaging, chest radiograph is reasonable in most ICU patients with a new fever. CT of the chest, abdomen, and pelvis can be reserved for those with localizing signs, or those who have had a recent surgery in that region, or if you have persistent unexplained fever. Not required routinely for every spike. For biomarkers, procalcitonin and CRP are optional adjuncts when the pretest probability of bacterial infection is a low to intermediate, and there's no clear focus of infection. So in this setting, a low value can support a not starting or stopping antibiotic therapy. When the probability of infection is high, on the other hand, like with shock or obvious sepsis, you will probably not be useful to send procalcitonin or CRP, and it would not be sensible to withhold the therapy at that point. So hemodynamically unstable high-risk patients should get early empirical antibiotic therapy in parallel with this workup. Stable patients with low probability infection or likely non-infectious causes should be managed more selectively rather than with automatic broad spectrum antibiotic coverage. So as far as infectious causes of fever is concerned, this is basically some epi data. The slide shows where most infectious fevers in the ICU come from when you looked at a mixed medical surgical cohorts, and by far the largest shares from respiratory infections. These are either hospital or ventilator associated pneumonias. They account for about 35 up to 60%, depending on what kind of acuity level you're training in or working in, and what kind of an ICU you're working in. But next is intra-abdominal infections, including C. diff, colitis, roughly at about 7 to 15%. UTIs, mostly catheter-associated, contribute about 8%, and bloodstream infections also make up about 5 to 15% of infections in the ICU. Finally, surgical site and skin and soft tissue infections also account for roughly about 5 to 10%, especially in the post-operative and patients who have been in the hospital for a long period of time. We'll dig a little bit into some of the data as far as pneumonias are concerned. So for ICU fevers or pneumonia, especially ventilator-associated pneumonia, this is a major contributor in many cohorts. Ventilator-associated pneumonias account for about half of all infections in ventilated patients. And the challenge is diagnosis is imprecise. Classical criteria like fever, purulent secretions, leukocytosis, or rales, or new infiltrate are sometimes non-specific, and fewer than 1/3 of patients who actually meet all these criteria or some of the criteria actually have a true pneumonia. Portable chest X-rays in the ICU are also of some limited utility with modest sensitivity, but very poor specificity. Lung ultrasound is emerging as a more accurate tool than chest X-ray, particularly in patients using that it's useful when CT is not feasible or when there's an effusion. It can also guide therapeutic or diagnostic tests on the pleural fluid. For microbiology, endotracheal aspirate cultures are easy to obtain, but a negative smear and culture have a very high negative predictive value and can help rule out ventilator-associated pneumonias. But a positive culture is a little harder to interpret because most ventilated ICU patients develop some degree of gram-negative colonization of the upper airway within about 48 hours. So growth alone does not equal infection. And this rate and the type of microbiology that colonizes the upper pharynx is actually very variable and depends on geographic location and the kind of antibiotic stewardship practices locally. As far as management for WAAW, broad guidelines would be first prevented from happening. The core elements of prevention would be protocol-driven light sedation, typically targeting RASS of about -2 to 0. Your patient should be comfortable and sleepy on the ventilator, but should be able to open their eyes and communicate with you for a few seconds. Early ventilator weaning, daily spontaneous awakening trials, and spontaneous breathing trials. All these are very important measures and correlate to mortality, ICU stay, a length of time on the ventilator. And these have been confirmed in many large trials, including the ABC trials. So that showed that pairing daily sedation interruptions with SBTs shorten the time on the ventilator and improves outcomes. Basically, anything that safely shortens the time a patient spends on a ventilator reduces your WAAW risk. But when it is suspected, we should start empirical broad antibiotic therapy guided by your unit's antibiogram, and because inappropriate initial therapy is strongly associated with high mortality, even if we correct the regimen later. So at the time of initiation, we must be disciplined about rapid de-escalation once culture data and clinical evolution sort of clarify what actually is going on. Antibiotic overtreatment is suspected WAAW is quite common in patients with a low likelihood of a true pneumonia. Short course strategies as brief as about 3 to 5 days in stable, improving patients have been associated with shorter ICU stays, lower cost, less resistance, and less superinfection with no increase in mortality compared to longer and traditional courses. And we'll go into some of that data later. Also use mercenaires to de-escalate. The more recent ICU ED work with PCR-based testing shows similar or better performance with a negative predictive value of a negative mercenaires of 97 to 99% when a swab is obtained within about 3 to 7 days of pneumonia onset. Provided that there's no prior MRSA colonization or no prior significant MRSA infections. Now, when you treat the patient with vancomycin for a long time in the ICU, obviously the reliability of that data goes down. The next slide is related to sinusitis, and this is surprisingly common, but it's often missed. It is a cause of fever in intubated ICU patients. There's been at least one prospective study looking at sinusitis and looked at sinusitis as the sole or contributing cause of fever in roughly about 30%, and about 16% as a sole cause in intubated patients being worked up for an otherwise unexplained fever. So the challenge is that these patients are usually sedated. They really can't report any facial pain or congestion, and your classic sinus symptoms are rarely evident. Like CLABSIs or UTIs or VAPs, sinusitis in the ICU is a device-related infection. Indwelling nasogastric tubes, endotracheal tubes, nasotracheal suction, catheters traumatize the mucosa and obstruct sinus drainage. And that promotes biofilm formation and subsequent infection and edema of the mucosa. So compared to nasogastric tubes alone, an oral endotracheal tube increases sinusitis risk by about 40%, and having both in would increase the risk by 200%. The highest risk would be with nasotracheal tubes. Even within 1 week of a nasotracheal tube, about 1/3 of the patients will have a purulent maxillary sinusitis. So CT sinus is the reference test, but mainly shows opacification and some air fluid levels. And only about maybe 38% of radiographic abnormalities truly represent an infection. So even when you do evaluate, you'll get a lot of noise in that data. Definitive diagnosis requires a sinus puncture and aspiration with culture, which is both diagnostic and therapeutic to a certain extent. Drainage alone often resolves the fever. Point-of-care maxillary sinus ultrasound can detect it in around 2/3 of CT-proven cases. So that's an evolving skill set that a lot of us can actually gain for ourselves with high specificity and is repeatable at the bedside. But sinus films, ironically, which were used in the initial data that showed this sinusitis prevalence, sinus films have a low yield. The practical takeaway, I guess, from this is that if your patient is persistently febrile, intubated with a nasal device and no other source, think about sinusitis, minimize the tubes. To be honest with you, I've really never seen anybody do sinus drainage or sinus puncture or ENT going into an ICU to do any of these drainages, but it is something to consider if you don't have a solution. As far as fever with diarrhea in the ICU, it's quite common. Most of the time, the diarrhea is from enteral feeds, from the direct effects of broad-spectrum antibiotic therapy. But when diarrhea is accompanied by fever, abdominal pain, or an elevated white count, we need to think seriously about C. diff. C. diff is responsible for about a fourth of all antibiotic-associated diarrheas in many ICUs. C. diff has actually replaced MRSA as the most common hospital-acquired infection. So any patient with new unexplained diarrhea, at least 3 completely loose stools that would conform to the shape of the container that they are collected in 24 hours, who have received antibiotics in the past 60 days or have been hospitalized for 3 or more days, should be considered at risk. Fulminant cases can present with minimal diarrhea and toxic megacolon. So so the systemic picture, fever, leukocytosis, abdominal distension also matters. A very thorough abdominal examination in every ICU patient will let you know when things are moving in the wrong direction. Listen for bowel sounds. Testing should be targeted, not routine. Colonization is frequent. We should send stool only from patients with a true new onset diarrhea. So in our hospital, we actually use a multi-step process where the nurses will actually talk to the provider ordering the test, ensure that the patient is not on any laxatives or any other cause of medication-induced diarrhea, confirm that the patient is actually having the loose stools, confirm that the stool conforms to the shape of the container, and then we reach out to the lab and get the testing done. The testing is usually a multi-step algorithm because C. diff is so frequently seen as a colonizer in the gut microbiome of ICU patients. The first test would be something very sensitive that picks up maybe your GDH antigen, and the second test would be very specific, like a nucleic acid testing for toxin-producing genes. So avoid testing, obviously, in asymptomatic patients, you'll pick up those colonizers, and we should not repeat testing within 7 days of the same diarrheal episode. It rarely leads to any useful information. Right. So the next one would be surgical site infections. We already talked about fevers in post-op patients, but some of those are very frequent, but some of them are actually true surgical infections. They occur in about 2 to 5% of post-operative patients. Roughly about 60% of them are thought to be preventable with a good perioperative practices, but I won't get into that now. For fever, timing is critical. In the first 48 to 72 hours after surgery, Fever is almost always non-infectious. Response to tissue to trauma, drugs, transfusions. And in at least one large prospective study, about 70% of fevers were non-infectious, especially in that early 3-day window. In a stable patient with a clean operating site, no localizing signs, you don't need to do routine cultures or empirical antibiotic therapy in that time frame within 3 days. But it's very concerning when it appears after about 96 hours or persists beyond the first few days, especially with wound drainage or changes or erythema around the incision sites or systemic instability. At that point, infection at the wound in deeper tissues or involving implanted material rises on the differential, and source control becomes key. Source control would be drainage, debridement, opening up the wound, and that's usually more important than simply increasing antibiotic therapy or starting antibiotic therapy. There are a few exceptions to where very early fever is worrisome. Sometimes people may aspirate. Major breaks in sterile field that the surgeon will usually tell you about, fecal contamination or something like that. Rarely, fulminant early infections can be a sign of clostridial myonecrosis or group A streptococcal infections. And these are very rapidly developing. They can develop within 24 hours, and they'll actually progress within hours. And if it's a necrotizing soft tissue infection. You can also have some anaerobic wound infections. They can be early, but they're usually fairly obvious with drainage, foul odor, rapid progression, crepitus. Those are the things you want to look for at the wound site, and obviously get your surgical colleagues also involved. Your surgical colleagues probably have a different perspective because they see hundreds and thousands of postoperative patients, so they understand what is normal postoperative fevers, and they understand when it's just not the routine and when to suspect infection. Their clinical acumen is something that you'll have to take into consideration. So the next thing is UTIs. For fever in the ICU, a true urinary tract infection is less common than we may think, although everybody loves to blame the urine for all causes of fever. The inpatient, outpatient, community, everywhere, UTIs are overtreated. A lot of time we're just treating colonizers or asymptomatic bacteria in patients who have completely other symptoms related to completely maybe interstitial cystitis or non-infectious etiologies. But in the ICU context, in an 18-month retrospective study of more than about 500 trauma ICU patients, the rate was about 16 UTIs per 1,000 catheter days, so decrease the catheter days. Almost all ICU patients have a Foley, and catheters become colonized very quickly. That's about 3 to 7% per day of catheter use. Catheter-associated bacteria occurs in about 30% of patients, but fewer than 3% of those bacteria patients develop bacteremia with the same organism. And pyuria doesn't have much because they may be colonized and patients will have white cells in their urine. The question is not is the culture positive, but the question is this a real UTI? The highest risk patients are those with Foleys in place for more than about 2 weeks. Women are at a higher risk, patients with prior antibiotic use or prior urological surgery. In those cases, consider sending a urine culture when you have a plausible clinical reason to do so, new fever without another source, some flank pain, or if there's an anatomical issue with obstruction and recent urinary tract surgery, or maybe if there's a bacteremia with a gram-negative that's also seen in the urine. Techniques matter. We should avoid culturing from a Foley that has been in for more than a few hours. And really never culture from the collection bag. If we're concerned, we should do a straight in and out catheterization or just replace the Foley catheter and sample the new catheter after cleaning. Needless to say, asymptomatic bacteria does not need to be treated. We'll go on to catheter-related, central line-related bloodstream infections. This is relatively uncommon also, roughly 0.8 to 6 episodes per 1,000 catheter days. Again, highly preventable with a good bundle, CHG disc, clean area, clean insertion strategies. But when it does occur, it is a major source of nosocomial bacteria, and it has a very large impact on institutions, as much as C. diff does. So risk increases with line duration, number of lumens, frequency of manipulation, and site insertion. Temporary dialysis catheters and femoral lines carry probably the highest risk of infection, whereas peripheral IVs, subclavians may be on the low end of the spectrum. Regardless, if you don't need the line, take it out. We should suspect catheter-related infection when an otherwise when an otherwise immunocompetent patient develops an unexplained bacteremia or fungemia, and when there's a pus at the insertion site or the tunnel is tender or erythematous, or when we grow an organism that is classically line associated, like Quack-Case negative staph, Staph aureus, and maybe even Enterococcus candida, and sometimes gram negatives too. So the differential time to positivity can help. If a culture is drawn from the line, turns positive more than 2 hours before a simultaneously drawn peripheral culture, that can support a diagnosis of a catheter-related bloodstream infection. But in practical purposes, you can always reassess the patient, ask the question, hey, if I'm even suspecting that line, do I need to wait for the cultures to come back? I would just take that catheter out and culture the peripheral blood. So if line suspect is if obviously that's helpful if you have an alternative access, look for tunnel infection, purulent septic thrombophlebitis, or any other metastatic complications associated with that. A routine culture of the distal catheter tip is sort of no longer recommended. Its positive predictive value is low, and many positive tips do not reflect a true catheter-related, central line-related bloodstream infection. About half of CLABSIs are due to gram-positive cocci, whereas the rest are a mix of fungal organisms, mainly Candida and gram-negatives. But a true multi-drug resistance is relatively uncommon in these central line-related bloodstream infections. So reasonably narrow empirical coverage is often appropriate rather than a very broad regimen. All right, so we're seeing a lot more immunosuppressed patients in our ICUs, a lot of patients on biologicals for autoimmune disease, a lot of patients getting solid organ and stem cell transplants and modern cancer chemotherapy. It's estimated that roughly about 3% of the US population now lives with some sort of immunosuppression or immunodeficiency. And in this group, fever almost always means an infection, or almost always has to be assumed an infection, especially among solid organ transplant recipients. Over 90% of febrile episodes are infectious. In neutropenic patients, we actually lower the fever threshold. So a single temperature of greater than 38.3 or 103 degrees centigrade or 101 Fahrenheit, which is your traditional definition. But it also looks at fevers over 100.4 or greater than 38 degrees centigrade, which is sustained for an hour with an absolute neutrophil count below 500. So many immunosuppressive drugs blunt that inflammatory response. So sometimes severe infections can present with only minimal fever or even hypothermia, which is particularly ominous sign. I remember an elderly patient coming into our ER who was on induction chemotherapy for I think it was AML. And came in with just fever. The patient was actually doing quite well, but when I put my hand on the patient's abdomen, he winced. That's all. That was the only physical examination. The rest of the labs just showed neutropenia. A CT scan showed typhlitis, and he went for surgery immediately. So these are the kind of things that can be missed and very subtle. Because exam and CT and chest X-ray can be falsely reassuring, we lean more on CT and advanced diagnostic in this population. In neutropenic patients with unexplained fever, CT chest shows pneumonia in roughly about 60% of patients. So pneumonia and lung infections are big here. And sometimes a chest radiograph may be unrevealing. You can use galactomannan and beta-D-glucan. They have a high negative predictive value. PCR testing for viruses or regionally important fungi such as histo or blasto or cocci, if you have risk for cocci, can be helpful when the clinical context supports them. Traditionally, fungal infections tend to produce a more clear and differentiated imaging pattern, but in an immunosuppressed patients, it can be quite variable, although nodularity or your classical signs of Aspergillus pulmonary infection, your crescent sign, ground glass opacity suggesting angio invasion are also very helpful for you to guide your management. So the next slide is basically the types of immunosuppression. So the risk is shaped by the type, degree, and the duration of immunosuppression. whether the problem is cellular, humoral, phagocytic, or anatomical. Typically, as you all know, in HIV, we depend heavily on the CD4 count. CD4 50 is very different from 350. A solid organ transplant patient, lung is often the weak point. Pneumonia is very high in that, so search for a pulmonary infection. The checkpoint inhibitors are a little different. These medications actually work by revving up the immune system. So opportunistic infection, so that you can have a host versus tumor activity. Opportunistic infections are less common than with calcineurin inhibitors. Instead, immune-mediated toxicities are more prominent, unusual skin findings, vasculitis, and rarely you can have hemophagocytic lymphohistiocytosis with high fevers, elevated ferritin, and other biomarkers that can lead to that diagnosis. Asplenic or splenectomized patients have a lifelong risk of sepsis from encapsulated organisms such as strep pneumo, Neisseria meningitidis, or Haemophilus. And in these patients, any fever is an emergency until invasive infections is ruled out or treated, or empirical coverage should be started for these encapsulated bacteria. Right. So coming to stewardship, sepsis is a hard diagnosis to make with certainty at the bedside. There's no single physical finding, lab test, scoring system that sort of proves sepsis and all the data associated with sepsis, especially in older comorbid ICU patients who have a lot of comorbidities in the ICU, patients who have tachycardia, leukocytosis, and some degree of organ dysfunction. When you look back at all the data, up to a third of the patients treated for presumed sepsis turn out to have a non-infectious mimic. That means a lot of patients receiving these broad antibiotic therapy with the associated nephrotoxicity, the C. diff risk, land up actually not having an infection. I think a key discriminator is shock. So in septic shock, the pretest probability of a true infection is very high, and the time penalty is very real. So in Kumar's study, each hour of delay in giving appropriate antibiotic therapy for septic shock was associated with about a 78% drop in survival. And subsequently, Samo and colleagues' work refined this. That steep hourly mortality penalty is seen mainly in patients on vasopressors, but there was no clear time mortality associated in patients who are not with septic shock or shock. So shock, we should not hesitate. Get cultures quickly, give antibiotic therapy early. Our goal is to get antibiotics in within 30 minutes, but data would say 45 minutes to 1 hour. For patients who are not in shock, the calculus is a little different. Baghdadi and colleagues showed that starting with a narrow therapy and broadening later, when new data supported it, often performs as well than maximum, then slamming the patient with maximum antibiotic therapy. But again, watch out for shock. A note about beta-lactams in the ICU and some pearls about PK/PD issues that we talk about in ID. And I think there'll be another talk in this group of talks about PK/PD specifically. But for beta-lactams in the ICU, which is our main workhorse, one core PK/PD idea is that efficacy is driven by the time above the MIC rather than by peak levels. So how long is the concentration of the drug higher than the MIC of the bug? What matters most is the free drug. How long is it going to stay above the MIC? And for intermittent infusions, some preclinical work suggests that bacterial killing is maximized when your level remains above the MIC for about 40 to 70% of the interval. And then on the other hand, with prolonged or continuous infusions, 3 or 4 times extended infusion, piperacillin, tazobactam, the goal is essentially to keep the concentrations above the MIC for the entire period of that time, so 100% of the time. So in practice, many studies and bedside approaches uses a similar surrogate, aiming for a trough that is at least 4 times the MIC at the end of dosing interval. A lot of earlier studies use that C minimum of 4 times the MIC. In early sepsis, a significant fraction of ICU patients do not reach this target with standard intermittent dosing because of larger volumes of distribution, augmented renal clearance, and other organ support that they may be like CRRT or ECMO or RRT. So one nuance is which MIC do we use? When we don't have the patient's actual isolate MIC, which is actually a practice that's becoming quite widespread, at least here in the US, we often plug in MIC 90 data or breakpoint value from the CLSI or the UCAST, and that makes target attainment look artificially poor. So when investigators use the true MIC of the patient's organism, the target attainment looks much better with far fewer patients appearing to be underdosed. Prolonged infusions and PK tailoring are therefore most likely to matter in patients with a higher MIC organism or who have altered clearance that are, rather than in every ICU patient on beta-lactams. And that's a good slide to segue into the next slide. The pharmacology of beta-lactams, like I said before, supports prolonged infusion. It makes sense that if I have the level of my antibacterial medication higher than the minimum concentration required to kill the bacteria or the MIC, I'll be doing a better job. And the surviving sepsis campaign recommended prolonged infusion in critically ill patients, sofosbuvir extended infusions, meropenem extended infusions. But it labels these as weak recommendations with a moderate quality evidence. And it's something to consider, especially for certain patients, but not mandated for all. But more recently, there have been larger randomized trials that came out last year. The Mercy trial that looked exclusively at meropenem and the Bling trial that looked at intermittent dosing versus continuous infusions. These were very robust trials. They enrolled more than 7,600 ICU patients. They compared continuous versus or prolonged beta-lactam infusions with the standard intermittent dosing. And despite having a better PK/PD target attainment in the prolonged infusion arm, there was really no difference in 28 to 90-day mortality. At least in the Blink-3 trial, it's around 24-25% mortality. That's why the guideline language is cautious. Pharmacologically, it makes sense. But in this population level, the outcome signal is modest. So the other issue is therapeutic drug monitoring for beta-lactams. Can it improve PK/PD target attainment? Yes, maybe if you do it frequently enough. It remains crucial. Therapeutic drug monitoring remains crucial, but mainly in vancomycin and aminoglycosides. But the goal is mainly to avoid toxicity rather than to determine efficacy. All right. So the other important consideration is the combination data. So this slide pulls together two stewardship themes. Which beta-lactam do we pair with vancomycin and how albumin affects dosing of some drugs in the ICU? Very controversial topics. First, the kidney story. Historically, multiple observational cohorts suggested that vancomycin plus zosyn or piperacillin-tazobactam or PIPSO is associated with about a 2 to 3-fold higher odds of creatinine-defined AKI compared with vancomycin plus cefepime or vancomycin plus meropenem. And those studies, mostly retrospective, showed creatinine bumps with uncertain impact on dialysis or mortality. So there's always been a debate about whether this reflects a true tubular injury or just some sort of functional change. And then there've been the newer studies, the ACORN study that came out, I think, in 2023. And that's a trial that really helps make clearer, made my decision easier. And my practice change a little bit. And so this was a large ED-MICU population in Vanderbilt. They did this study in Vanderbilt. Most of the patients also received vancomycin over 80%. Zosyn was given for a median of about 3 days. The combination was given for a median of about 3 days and did not increase AKI or death compared to cefepime and vancomycin. And in fact, when they looked at the cefepime group, they noticed more neurological adverse effects and fewer delirium and coma-free days in the ICU. So for short empirical courses, especially for unstable patients where anaerobic or polymicrobial coverage matters, vancomycin plus piperacillin-tazobactam looks kidney safe compared with vancomycin plus cefepime. But for prolonged therapy or very high renal risk patients, it's still reasonable to think about it and individualize your choice. I can tell you a lot of our critical care doctors have moved away from the vancomycin and cefepime because of the neurological issues. They don't want a patient who's delirious or they don't want a patient whom they're having difficulty extubating in the ICU if they don't need to. The second part of this slide shifts a little bit to the hypoalbuminemia and dosing. There's been at least one large review in 2011 that looked at this issue. Not too much has been done after that. For ceftriaxone and ertapenem, both about 85 to 95% protein bound. When you have hypoalbuminemia, This ultimately results in less drug bound to albumin and more free drug. So the free drug gets excreted or gets distributed in tissues and doesn't do what it's supposed to do. So hypoalbuminemia doubled the apparent volume of distribution and clearance compared to healthy controls. And standard dosing sometimes failed to achieve adequate time above MIC for ertapenem and ceftriaxone. So teicoplanin, aztreonam, daptomycin, these are all even cefazolin are all highly protein bound. So think about this issue if your patient is not responding. And I think one of my last focuses for this talk, I think I'm doing well on time. The last stewardship theme is de-escalation and duration of antimicrobial de-escalation, switching from broad to narrow agents, dropping unnecessary combination drugs, or stopping antibiotic altogether when infection is no longer likely. It's now supported by ICU data. Multiple observational studies and small RCTs show that de-escalation is safe in critically ill patients. The Diana study, which is not actually a very great study, but it did show it followed about 1,500 patients across 152 ICUs in 28 countries. Only about 16% of these patients in the study were de-escalated by day 3, but in those patients, there was no increase in 7 or 28-day mortality, and clinical cure was actually higher in the de-escalated group. So meta-analysis is consistent with this sort of conclusion. De-escalation is not associated with harm, and at least one shows some benefit. The second pillar is using the shortest effective duration across many infection types. Multiple trials show that shorter antibiotic courses are just as effective as longer ones when the patient is improving. There was one, the REGARD WAAW trial, when patients with WAAW were randomized to individualized short course therapy, which was no more than 7 days, and as short as 3 to 5 days, depending on defervescence, hemodynamic stability, and culture results, versus usual care with at least 8 days. And the median duration in this group was 6 days, and the short course group was versus 14 days in the usual group. And definitely the short course was non-inferior, while causing far fewer antibiotic side effects. And observational data also support short courses in this setting. So in clinical practice, duration and decision still will depend on you, on your bedside, on your good history, on your bedside assessment. Are they febrile, stable, off pressors? Is the source controlled? Biomarkers can help occasionally with stopping, but never an indicator of whether or not I should start. And they don't substitute for clinical judgment. Together, early de-escalation and a thoughtful short course therapy allows us to treat real infections while minimizing toxicity. So to close, I guess fever in the ICU is not an enemy. It's just a signal. It's just another data point that we have to integrate into our analysis. About half of our patients will have at least one febrile episode, and only a fraction will have a treatable infection. I guess our job is to not reflexively kill the fever or blanket them with antibiotics. It's to get a history, interpret the story of the fever, the story the fever is telling. And if we can pause, think systemically, and use antibiotics only when they're absolutely needed, I think we'll be able to protect our patients and save our ICU's microbiome. And with that, I conclude. And if there are any questions, I'll be happy to answer them now.
Yeah. Thank you, Rahul. You have covered quite a bit of WAP and different syndromes like sinusitis, CRBSI, UTI, and also special populations like immunocompromised host and people who are on different immunocompromising drugs. And when to give antibiotics and de-escalation in the ICU. Quite comprehensive. There's a few questions. We will take 1 or 2 questions. In which clinical scenario do we need to add MRSA coverage along with broad gram-negative coverage? And in which situation would empiric antifungal coverage be justified? So when is MRSA coverage and when is antifungal coverage?
Okay, so that's probably another hour-long talk, but I'll tell you, always go back to your fundamentals. Find out in your community where you're working, how frequent is MRSA. You have to know, A, what's your community prevalence? B, what is your hospital ICU prevalence? C, what is your hospital ward prevalence of MRSA? And all those are infection prevention and control departments initiatives. They will usually have that data. So having that data, you will automatically understand what is your pretest probability. The second is, if you don't have that, with that epidemiological data, the second thing you have to do is identify if the patient has had risk factors for these drug-resistant organisms like MRSA. For MRSA, one of the biggest predictors of a true MRSA infection is if the patient has had a previous infection with MRSA. And that correlates very well with pneumonias and ventilator-associated pneumonias. So if you look back into the patient's microbiology and see within the year if they've had MRSA infections in the lung, definitely you want to keep MRSA on before you get any other data. MRSA PCR NAIRS will take a few hours to come back. So every ICU patient, screen them for MRSA. Always know that you have that in your back pocket. And like I said, a negative MRSA NAIRS, if your patient has not been treated extensively for less than 6 to 7 days of antibiotic therapy, has a very high negative predictive value. So even if you do give a dose of vancomycin, you can always de-escalate the vancomycin with a negative MRSA NAIRS safely. The other thing is the other thing I think that's important is when your patient comes in with septic shock and you don't have any time to think, there's no harm in giving a dose of vancomycin and cefepime or vancomycin and zosyn, broadly covering both MRSA and Pseudomonas. If your clinical presentation is undifferentiated, then you don't know the source, or you think it's a potential source, pulmonary source, or if the patient is immunosuppressed. These are the areas I'd be very aggressive. I can go on, but if that's specifically in the neutropenic
it
patient.
answered the question. Generally, in our setting also, we don't need to give MRSA coverage if the patient is not in shock. And we give MRSA coverage if there's a skin and soft tissue infection in the patients in the ICU. Otherwise, in pneumonias, our incidence of MRSA is a bit low. So it depends on the hospital where you practice, the antibiogram, and the microbiological profile. So there's another question where they wanted to know about C. difficile. It was not something which was very clear to Pooja. Something about, could you please repeat the testing for C. diff part?
Yeah, so Kavita, how do you guys do the C. diff testing? Is it just you do the PCR testing?
No, we just do toxin testing and GDH.
So that's your two-step. So you do a GDH. That's exactly what the multi-step protocol is. So you guys are doing state of the art. You're checking a GDH, which is a very sensitive test that's going to pick up a lot of C. diff colonizers and infections. But you're also doing a very specific test, which is your EIA for your toxin. And that both have to be positive for you to consider that to be a true infection. If only the GDH is positive, consider it to be a colonizer. And then the next question would be, in the setting of colonizing organisms, do I really feel like despite the toxin being negative, do I still have to treat? And that'll be a clinical judgment.
Yeah, and if there's a discrepant test and if GDH is positive and toxin negative, would you go for a PCR?
Not necessarily, not reflexively, not all the time. So in our hospital, we actually directly do the PCR. But your PCR is also going to pick up your C. diff, and it's going to identify toxigenic strains if you're identifying the toxin gene. But it doesn't mean that those toxin genes are active. So your EIA toxin assay, if it's negative with a positive GDH, it's a very good probability that you're dealing with a colonizer. But it's again clinical judgment on whether or not this patient came in with the right story, antibiotics, has fever, leukocytosis, and colitis on examination, and is deteriorating on broad antibiotic therapy. Yes, still consider that this could be a true case of C. diff. Stop your broad antibiotic therapy and start your C. diff treatment. So that's a clinical judgment. Very infrequently do I do that though, but every now and then we'll make that call, and when you have discordant results, we'll still treat.
And when do you give? Did you answer when do you give antifungal, empiric antifungal?
Almost never in the immunocompetent patient. Almost never. Rarely in extremely sick immunocompromised patients who have imaging that's consistent with a fungal infection or have an epidemiological background or a history of those kind of fungal infections or a very clear epidemiologically clue, like in the US, if you have people coming from Arizona or the southeast part of US, there's a lot of cocci, so we jump to cocci treatment very quickly. Very rarely in neutropenic patients are you going to give up upfront antifungal therapy. Rarely, every now and then, a patient on TPN coming in with high-grade fevers and visual abnormalities, or just high-grade fevers and septic shock, will broaden with antifungal therapy. And very rarely, if patients come in late failures on broad antibiotic therapy for intra-abdominal sepsis, we'll add on when they come to the ICU antifungal coverage, but it is limited. And I can tell you that practice is pretty ubiquitous, but it's a little different in lung transplant ICUs and cardiac transplant ICUs, where the threshold to initiate antifungal therapy will be lower right off the bat, but it's very infrequently done.
Yeah. So one question, last question. Are there any practical alternatives to endotracheal aspirate samples? What about protected ball do you have any
Yeah.
alternatives to endotracheal aspirate samples? Mini ball.
Yes, absolutely. There's data that suggests that your mini BAL is going to be a better clinical sample than your endotracheal aspirate. So if you have the technical capacity to do that when you have a high clinical suspicion, that would definitely be a better sample. Your endotracheal aspirate can be a guide. It can definitely help you if it's negative. If you have a clearly decompensating patient with fever, altered hemodynamics, and ventilator parameters changing with a new infiltrate, you can work on the tracheal aspirate. You don't always need a mini BAL.
Yeah, I think we have covered a lot in this session with two speakers, and we will conclude. Tomorrow we will have two important sessions, common mistakes in antibiotic prescribing and also antifungal stewardship. So which will cover something about fungal, when to prescribe antifungals and about antifungal stewardship. So do join us tomorrow, and thank you very much, Rahul and Bal Vinod, and good night.
Thank you. Good night.
Good night.
Thank you, madam.